The human brain is arguably the most complex biological structure known to science, serving as the central command center for the nervous system and governing every thought, movement, sensation, and vital function. Encased within the rigid protection of the skull, the brain exists in a delicate state of equilibrium, floating in cerebrospinal fluid, which acts as a cushion and a nutrient delivery system. This closed environment, while protective, presents a unique physiological challenge known as the Monroe-Kelly doctrine, which posits that the skull is a fixed volume. Therefore, the introduction of any additional mass, such as a tumor, disrupts this balance, forcing the displacement of fluid, blood, or brain tissue itself. Because the brain is divided into distinct lobes and regions, each responsible for specific tasks ranging from vision and speech to motor control and personality, the manifestation of a tumor is rarely uniform. Instead, the symptoms produced are directly correlated to the tumor's location, size, and rate of growth. Understanding the early signs of a brain tumor requires a shift in perspective from looking for general illness to observing specific neurological deficits or changes in function. These growths, whether benign or malignant, act as space-occupying lesions that exert pressure on sensitive neural pathways. Early detection is often complicated by the brain's remarkable ability to compensate for damage, a phenomenon known as neuroplasticity, which can mask symptoms until the growth reaches a critical threshold. Furthermore, many symptoms mimic common, less severe conditions like stress, fatigue, or migraines, leading to potential delays in recognition. By examining the neuroscience behind these physiological changes, we can better understand how a disrupting mass manifests in daily life. This exploration identifies 8 specific indicators that medical professionals analyze when assessing neurological health, focusing on the subtle but persistent ways the body signals that the delicate intracranial environment has been compromised. Step 1. The distinctive pattern of headaches. Pain is the body's most primal alarm system, yet the brain tissue itself possesses no pain receptors, a fact that allows for awake brain surgeries to be performed with only local anesthesia for the scalp. Consequently, the headaches associated with brain tumors do not arise from the brain hurting, but rather from the tumor stretching the sensitive covering of the brain, known as the dura mater, or displacing blood vessels and nerves. The specific presentation of these headaches often differs significantly from the tension headaches or migraines that are common in the general population. In a neurological context, particular attention is paid to the timing and progression of the pain. A headache that presents immediately upon waking in the morning is a classic, though not exclusive, indicator of increased intracranial pressure during sleep. When the body is in a recumbent or lying position, the drainage of cerebrospinal fluid is naturally reduced, and carbon dioxide levels in the blood may slightly rise, causing blood vessels in the brain to dilate. In a healthy individual, the brain accommodates this minor volume change without issue. However, when a tumor is present, the available space inside the skull is already compromised. This leads to a spike in pressure during the night, resulting in a headache that is most severe upon waking and may improve as the person stands up and gravity assists in fluid drainage. Furthermore, these headaches often do not respond to standard over-the-counter analgesics in the expected manner. Another critical feature is the worsening of pain during actions that momentarily increase pressure inside the head, such as coughing, sneezing, or bending over, a phenomenon known as the Valsalva maneuver. Recognizing this non-pulsating, dull, and persistent pressure requires differentiating it from the stress-induced tightness or the photosensitive throbbing typical of migraines. Step 2. Adult onset seizures. The brain operates through a sophisticated network of electrical impulses where billions of neurons fire in synchronized patterns to facilitate communication between different regions. A brain tumor can disrupt this electrical harmony, acting as an irritant that triggers chaotic, uncontrolled electrical discharges, commonly known as seizures. In the context of oncology, the onset of a seizure in an adult who has no prior history of epilepsy or head trauma is considered a highly significant clinical event. Unlike childhood epilepsy, which often has genetic or developmental origins, a first-time seizure in adulthood prompts immediate neuroimaging to rule out a structural cause, such as a lesion or mass. The tumor alters the chemical environment of the surrounding neurons, making them hyperexcitable and prone to misfiring. The manifestation of the seizure depends entirely on where the tumor is located. If the electrical storm remains localized to one area, it is termed a focal seizure. For instance, a tumor in the parietal lobe might cause a sensory seizure, resulting in a sudden sensation of tingling or numbness in a specific limb, while a tumor in the temporal lobe might trigger a sensation of déjà vu, a strange smell, or a rising feeling of nausea, known as an aura. If the abnormal electrical activity spreads across the entire brain, it results in a generalized tonic-clonic seizure, characterized by loss of consciousness and convulsions. Often, subtle focal seizures occur for weeks or months before a major event, presenting as momentary spells where the individual might stare blankly, smack their lips, or experience transient confusion. These episodes are frequently dismissed by patients as moments of zoning out, yet they represent a fundamental disruption in neural circuitry caused by the encroaching mass. Step 3. Unexplained vision anomalies. The visual system is one of the most extensive networks in the brain, extending from the eyes at the front of the head through the optic nerves, crossing at the optic chiasm and terminating in the occipital lobe at the back of the skull. Because this pathway traverses such a large area, it is highly susceptible to compression by tumors growing in various locations. Vision changes caused by brain tumors are often gradual and may not be immediately noticed by the individual, who might inadvertently compensate for the deficit. Unlike the blurring caused by aging eyes or the need for new glasses, neurological vision loss often involves specific field cuts, areas of blindness in the visual field that the patient cannot see. A classic example involves a tumor pressing on the optic chiasm, the junction where optic nerve fibers cross. This specific pressure can cause bitemporal hemianopsia, a condition where the individual loses their peripheral vision on both sides, creating a tunnel vision effect. In daily life, this might manifest as constantly bumping into door frames, missing objects placed to the side, or having difficulty changing lanes while driving. Alternatively, a tumor in the occipital lobe might cause complex visual hallucinations or the loss of vision in just one quadrant of the visual field. Furthermore, increased pressure inside the skull can compress the nerves controlling eye movement, leading to diplopia, or double vision. This is often described as seeing two images side by side or atop one another, which persists even when the individual is not straining their eyes. Ophthalmologists can sometimes detect these intracranial issues early by examining the back of the eye for papilledema, a swelling of the optic disc caused by high pressure within the skull. Step 4. Progressive cognitive and memory decline. While memory lapses are often attributed to aging or fatigue, cognitive changes induced by brain tumors tend to be more persistent and progressive, particularly affecting executive functions. The frontal and temporal lobes are the primary seats of memory, reasoning, multitasking, and planning. A tumor infiltrating or pressing on these areas acts much like a slow-moving disruption to the brain's filing system and processor. The type of memory loss associated with these lesions is often distinct from the forgetfulness of dementia, though there can be overlap. It frequently presents as short-term memory deficits combined with a significant struggle to focus on complex tasks that were previously manageable. Beyond simple forgetfulness, family members often notice a decline in the individual's ability to process information or solve problems. Routine activities that require multiple steps, such as balancing a checkbook, following a recipe, or managing a schedule, become confusing and overwhelming. This cognitive slowing, often termed psychomotor retardation, creates a noticeable lag in processing. The individual may take longer to respond to questions or appear perpetually distracted. In cases involving the temporal lobe, the deficit may be specifically related to verbal memory, where the person struggles to retain information they have just heard. Because these changes can be subtle and gradual, they are frequently rationalized as stress or burnout. However, from a neurological standpoint, they represent a compromise of the neural networks required for higher-order thinking, signaling that the brain's processing reserves are being depleted by the presence of the tumor. Step 5. Personality and mood alterations. Perhaps the most distressing changes for families to witness are those involving personality and behavior, as these strike at the very essence of who a person is. The frontal lobe of the brain is responsible for regulating emotions, inhibiting impulses, and maintaining social appropriateness. When a tumor impacts this region, it can essentially disconnect the individual's personality filters. This phenomenon is well documented in medical history, most famously with the case of Phineas Gage, and remains a key diagnostic marker today. These shifts are often abrupt or uncharacteristic, presenting as a stark departure from the person's baseline temperament. A formerly mild-mannered and patient individual may become irritable, aggressive, or prone to outbursts of anger with little provocation. Conversely, a vibrant and active person might sink into a state of profound apathy, losing interest in hobbies, work, and social interaction, a condition often misdiagnosed as clinical depression. However, unlike standard depression, this apathy is frequently accompanied by a lack of insight. The individual does not feel sad, but rather devoid of drive and initiation. In some cases, the loss of inhibition leads to socially inappropriate behavior or a lack of empathy for others. These changes occur because the tumor interferes with the prefrontal cortex's ability to regulate the limbic system, the brain's emotional center. Observing these shifts requires a careful distinction between psychiatric conditions and neurological trauma, identifying that the root cause is structural rather than purely chemical. Step 6. Unexplained nausea and vomiting. Nausea is a nonspecific symptom common to many ailments, from food poisoning to viral infections. However, when associated with a brain tumor, nausea and vomiting possess unique characteristics driven by neurological rather than gastrointestinal mechanisms. This symptom is frequently linked to tumors located in the posterior fossa, the small space near the base of the skull, containing the cerebellum and brainstem, or those that cause a significant increase in intracranial pressure. The brainstem houses the vomiting center, a collection of nuclei that control the emetic reflex. Direct compression of this area or generalized pressure can trigger this reflex independently of the stomach's contents. Clinically, this type of vomiting is often described as projectile or occurring without the preceding sensation of severe nausea that usually warns of an impending episode. A distinct pattern is the presence of nausea immediately upon waking in the morning, similar to the headache pattern discussed earlier. During sleep, the horizontal position increases intracranial pressure. Upon waking and moving, this pressure shift stimulates the vomiting center. Once the vomiting occurs, the pressure may temporarily decrease, leading to a reduction in headaches, which can confusingly reinforce the idea that it was merely a stomach bug. If an individual experiences persistent, unexplained nausea that is not related to food intake and is accompanied by headaches or dizziness, it points away from the digestive tract and toward the central nervous system as the source of the disturbance. Step 7. Motor weakness and sensory numbness. The brain controls movement and sensation through a highly organized map known as the homunculus, located along the motor and sensory strips of the cerebral cortex. The left side of the brain generally controls the right side of the body, and vice versa. Consequently, a tumor growing in the right hemisphere often manifests as weakness or numbness on the left side of the body. This asymmetry is a hallmark of neurological compromise. Unlike the generalized fatigue or weakness felt during a flu, this motor deficit is focal, meaning it affects a specific limb or region. An individual might find themselves repeatedly dropping objects from one hand, dragging a foot while walking, or feeling a heaviness in one arm that makes it difficult to lift. Sensory changes often accompany these motor deficits. The parietal lobe is responsible for processing sensory input, including touch, temperature, and pain. A tumor interfering with this region can cause hemiparesthesia, a persistent numbness or tingling sensation, often described as pins and needles, in an arm, leg, or side of the face. This sensation does not fluctuate based on position, unlike a limb falling asleep due to restricted blood flow. Over time, the weakness may progress to paralysis if the tumor continues to grow and damage the motor neurons. Clinically, doctors test for pronator drift, where a patient closes their eyes and holds their arms out. If one arm involuntarily drifts downward and rotates, it suggests a weakness in the motor pathways originating in the brain, signaling a structural lesion rather than a muscular injury. Step 8. Balance and coordination difficulties. The cerebellum, located at the back of the brain just above the neck, is the master control center for balance, coordination, and fine motor skills. Although it occupies a relatively small volume, it contains more neurons than the rest of the brain combined. When a tumor develops in or presses upon the cerebellum, the primary symptom is ataxia, a loss of muscle control and coordination. This often presents as a disturbance in gait. The individual may walk with a wide stance to maintain stability or veer to one side unexpectedly. The loss of equilibrium can be profound, leading to dizziness or vertigo that is not related to inner ear infections. Beyond walking, fine motor tasks become increasingly difficult. Activities requiring precision, such as buttoning a shirt, writing, or using utensils, become clumsy and uncoordinated. This is not due to weakness in the muscles, but rather the brain's inability to calculate the distance and speed required for the movement. A deficit, known as dysmetria. Friends or family might observe that the person appears intoxicated, slurring their speech, or stumbling, even when they have not consumed alcohol. This drunken appearance is a direct result of cerebellar dysfunction. Furthermore, nystagmus, a condition where the eyes make repetitive, uncontrolled movements, often accompanies cerebellar tumors, further disrupting balance and depth perception. Recognizing these coordination issues involves noticing a disconnect between the intention to move and the execution of that movement, highlighting a disruption in the brain's intricate guidance system. The detection of a brain tumor is rarely the result of a single dramatic event, but rather the accumulation of subtle, progressive changes that disrupt the body's normal physiological rhythm. The 8 signs explored, ranging from distinctive headaches and adult-onset seizures to shifts in personality and loss of motor control, represent the diverse ways in which a space-occupying lesion compromises neural function. Because the brain is the seat of the self, symptoms are often misinterpreted as psychological issues, aging, or stress. However, the persistence and progression of these signs serve as the key differentiators. In the realm of neurology, the constellation of symptoms is often more telling than any single indicator. A headache alone is common. A headache combined with morning nausea and visual disturbances creates a specific clinical picture that warrants investigation. Modern medical imaging, particularly magnetic resonance imaging (MRI), provides the definitive view required to assess these structures, allowing for early intervention, which significantly impacts prognosis. Understanding these biological signals empowers individuals to advocate for their health, moving from ignoring subtle deficits to seeking the necessary neurological evaluation.